So we're going to break a little bit from the tradition that typically is associated with grand rounds, and Martha's going to present some patient stuff later, and I'm going to start off by providing some background on CLL, or chronic lymphocytic leukemia, talk a bit about the pathogenesis, specifically how antigen receptor stimulation is playing an important role in this particular disease, and then also touch on immunoglobulin, two tests that we do at ARUP that have prognostic value, immunoglobulin gene analysis, as well as ZAP70. And then Martha, as I mentioned, will present some patients and how this all goes on in the clinic, as well as talk about treatment. So chronic lymphocytic leukemia, or CLL, is a neoplasm of small mature B cells, or B lymphocytes. It's the most common leukemia affecting adults in North America and Europe. Represents about 30% of all leukemias. Interestingly, it doesn't appear to affect Asians much at all. So there's some sort of genetic thing going on there, even when they move to the US and start eating at McDonald's. The incidence is 4 cases per 100,000 people per year, which in the US turns out to be about 10,000 new cases. CLL is a disease primarily of older individuals. The median age is about 65, and there are very few people under the age of 50 that have got CLL. And there's also a male predominance for some reason that nobody really has explained yet. So in addition to seeing small mature B cells on peripheral blood smears, you typically also see things called smudge cells, which are just kind of blown apart CLL cells that result from the increased fragility of the CLL cells when you try to make the smear. Diagnosis of CLL now requires finding 5,000 or more CLL phenotype cells per microliter of peripheral blood. So the CLL phenotype, CLL cells are B cells, so they express 19 and 20, which are pan-B cell antigens, but they also express CD5. CD5 is typically on T cells. It's only on a small subpopulation of B cells. In addition to that, they express CD23, and the surface light chain, or immunoglobulin, they express is also somewhat attenuated or described as weak. The cutoff of 5,000 is somewhat arbitrary and potentially could get revised upward. This was just sort of recently implemented, but it was mainly put in place to try to distinguish people that have got small CLL clones floating around in their blood from patients with a larger disease burden that potentially would go on to require treatment and that sort of thing. So, and I'll be talking more about this later, but it's called monoclonal B-cell lymphocytosis, or lymphocytosis, and this basically represents a benign expansion of that's usually small in size, maybe 50 to 100 cells per microliter of CLL phenotype cells that only rarely progress into CLL, but it's basically a CLL precursor lesion. So the clinical course of CLL, most patients are asymptomatic when they're identified. It's often picked up by routine screening tests. And clinical behavior is highly variable. Some patients, aren't affected at all. For the most part, other patients have very progressive disease. So that's sort of heightened the interest in prognostic markers of late. Patients typically aren't treated until they're symptomatic, in part because early treatment has not shown to improve survival. Although Martha's the expert in this, and she'll go over that in a lot of detail. So as I mentioned, I'm going to try to focus a little bit on the B-cell antigen receptor that's playing an important role in the development of this neoplasm. And it's sort of cartooned here. It consists of surface immunoglobulin, which represents the antigen binding part, coupled to a bunch of signaling moieties. So this is a key molecule for normal B-cell differentiation and survival. If a normal B-cell loses this antigen receptor, it dies. It needs some sort of tonic stimulation going through it. And it's also the key molecule in terms of getting clonal expansion of B cells and this sort of thing. So it's not unreasonable to suspect that the B-cell antigen receptor would also be playing an important role in the development of B-cell neoplasms, especially the less transformed type that haven't figured out ways to avoid this particular pathway. So the antigen binding part of the B-cell receptor is shown in a little more detail here. So this is the immunoglobulin molecule. It's composed of 2 heavy chains. There are these bigger things. This thing I don't think is working. Well, whatever. I don't think it's working. Yeah, barely, but you can't see it. So it's a white background. Anyhow, the larger, so you've got 2 heavy chains that are the bigger moieties up there, and then 2 light chains on the outside. Everything's held together by disulfide bonds. So the antigen binding part is at the end here. That's encoded by variable genes. And I think most people are aware that variable genes undergo rearrangement during B-cell differentiation. This is a cartoon showing how heavy chain gene rearrangement goes, and you've got about 50 different variable gene segments, 27 or so diversity segments, joining segments. DJ joining occurs first, followed by VDJ joining, and then you get a transcript where this is all sort of put together. So this is a way that the immune system basically generates diversity then to be able to combat or identify different pathogens. And then the other way B cells can generate diversity is through somatic hypermutation. So this is a mechanism in normal B cells that generates antibodies with higher binding affinities than may come out initially. So mostly occurs in lymph node germinal centers. Point mutations are introduced in both the heavy and light chain variable genes, and then B cells that express higher affinity immunoglobulin variants on their surface are selected through clonal expansion by interacting with antigen-presenting cells and T cells in a process called affinity maturation. So this hypermutation thing only occurs in B cells, doesn't occur in T cells, and is responsible for generating high affinity antibodies. So as I mentioned, the clinical course of CLL is highly variable, and these two papers that appeared in the same issue of Blood back to back generated a lot of interest in 1999, basically showing that the mutational status of the immunoglobulin genes used by CLL cases could separate CLL into two groups. One that had good prognosis, that's the mutated group up on top, and the ones that had expressed immunoglobulin genes that had unmutated variable genes, and that's shown on the bottom. Okay, so the difference in survival, at least in this study, this figure was pulled from this study here, was 25 years versus 8 years. So immunoglobulin gene analysis involves looking at point mutations in heavy chain variable gene segments and then comparing those. So the way that's done is you amplify up the variable gene, look at the germline counterpart that's usually in a database, and then figure out where the point mutations are and how many that you've got. And this separates, as I just mentioned, CLL into two groups. The mutated group has good prognosis, unmutated, not so good. The cutoff people use typically is 98%, which is somewhat arbitrary, but was initially put in to supposedly handle polymorphisms that occur sometimes within these genes. Because they're only looking at germline genes in their databases. They're not cloning out the germline genes from individual patients. However, subsequently people found that the degree of polymorphism really isn't that high. And so I think part of this was just because it generated a nice cutoff or separation between the good and bad prognostic groups. But anyhow, this is the convention that everybody uses. So if the gene shows 98% or more homology to the germline segment, it's called unmutated. And if it's less, then it's mutated. It's interesting that you don't find any mixing between the mutated and unmutated CLL types, suggesting that they potentially represent two separate sort of lineages and may have different cells of origin as well. Initially, people thought that the non-mutated CLL represented like a naive B cell, and then the mutated one was one that went through the germinal center and that sort of thing. But that has since been shown to be not true, and that all CLL looks like it's involved with antigen recognition. So why is CLL prognosis related to immunoglobulin gene mutational status? That's because antigen receptor stimulation is important for the development and progression of CLL. And my saying this is based on observations in numerous studies showing that CLL shows non-random use of variable gene segments. So in other words, mutated CLL shows preferential use of some variable gene segments, and unmutated group shows preferential use of a different set of immunoglobulin gene segments. But more importantly, about 20% of cases express remarkably similar variable genes, including not just the variable gene segment, but the diversity and joining segment and the stuff in between. So they're virtually identical in maybe 1 to 2% of cases. This is more evident among the non-mutated cases, but finding CLL cases from different people more or less expressing the same immunoglobulin gene suggests that they're recognizing the same antigen and that antigen is basically driving the process. I mean, so this is just a cartoon to give you an appreciation of how rare this is. So this is the variable gene down here, and what I'm showing are what are called complementarity determining regions, and 2 of them are contributed by the variable gene segment, and this third one, CDR3, is made up of the diversity segment and randomly templated nucleotides that get put in during this VDJ rearrangement process. So these are randomly templated in, and they could represent anything. And not only that, but these diversity and joining segments get trimmed down by nucleases. So this CDR3 is super variable. It's typically considered to be a clonal marker. So these CLL cases I'm talking about from different patients actually have identical CDR3s as well. And these CDR3s, as it's mentioned up here, encode the antigen binding pocket. So, and they used to be called hypervariable regions. But so that's the remarkable thing about CLL, is that a lot of cases express very similar immunoglobulin genes, and people have actually called this stereotopity, and they have different stereopic groups or stereotypic groups and this sort of thing. So it's quite interesting. This is a little busy, but it's just, it shows you different variable gene segments used by, in a study that was published in the British Journal of Hematology, 2005, I think, of about 60 patients, and showing you the difference really in variable gene segments between normal peripheral bloods, mutated CLL, and non-mutated. So the unmutated CLL expressed a lot of this V169 gene, and I apologize, this pointer's not working out. The V169 is the thing down to the left, and the mutated, and then that's not expressed much by either the mutated CLL or normal peripheral blood B lymphocytes, whereas the mutated type of CLL expresses a lot of this V434. So this is just a slide showing you the biased use of variable gene segments. This just highlights the fact that the CDR3 region, these are different CLL cases. On the top show identical CDR3 regions, and the ones at the bottom show the very similar CDR3. So the probability of this happening by chance, I think, is something like 1 in 10 to the 14th or something like that. And this slide just highlights the fact that not only do you see very similar heavy chain genes, but a lot of these cases have, again, almost identical light chain genes. So cases that express this particular heavy chain gene called V321 also typically express this light chain gene shown over here. And not only that, but you have, again, in the light chain, almost identical CDR3s. So, and the other exception to the rule between mutation and non-mutation is that cases that express this V321 gene have a bad prognosis regardless if it's mutated or not mutated. All right, so, we have we're one of the few labs that has this immunoglobulin gene analysis test, and I just sort of highlighted how it works here. Make RNA, and then amplify up the heavy chain genes using VH family specific and JH leader primers. We also have, importantly, a primer that recognizes this V321 gene, because that one has a bad prognosis regardless of whether it's mutated or not mutated. And the other problem is that if you just use leader primers, consensus leader primers, you often can miss this gene because it's mismatched a little bit anyhow. And if you have mutations in your gene, the consensus primers for that family often don't work, and that would be a bad one to miss up. And then we just compare them to the germline genes in the standard database, and then report out the gene segment and percent homology. This just shows some electrophoresis gels of PCR products generated after amplification with some of the leader primers. And the way the assay works is we use 4 PCR reactions. One contains a primer to the VH1 family, one to the VH3, and one to the VH4. And these make up about 90% of the variable gene segments. And then we have this other lane here, or reaction, that contains some of the infrequently used primers against the infrequently used genes. And one of those is this V321. And as you can see here, the V3 consensus primer, even though this is a VH3 family gene, doesn't really pick it up, or if it does, it picks it up poorly. I'm not sure if we sequenced it or not. You could also amplify up normal B cells, and VH3, like half of your variable gene segments are VH3 family. So this is just normal, probably normal contaminating B cell stuff here. But so you need that to pick up the V321. So shortly after it was appreciated that CLL could be separated into sort of 2 groups, mutated and non-mutated, people started doing microarray analyses to try to figure out, the genetic basis for this difference. And basically what was discovered, and again, 2 sort of landmark studies that appeared in the same issue of the Journal of Experimental Medicine by Lou Stouts and Ricardo Della Favera's group, indicated that both types of CLL, mutated and unmutated, share a common signature that's distinct from other B-cell neoplasms like follicular lymphoma. And interestingly enough, they were both similar to memory B cells, again arguing that they're both antigen experienced, which is also what the immunoglobulin gene data says. And there were a limited number of genes that you could distinguish mutated from non-mutated CLL, and one of those genes was something called ZAP70, which was the actual best discriminator between the non-mutated and mutated types. So ZAP70, or zeta-associated protein of 70,000 kilodaltons, is an interesting molecule. It wasn't even appreciated to be on B cells until after these expression array experiments. But it plays a critical role in T-cell antigen receptor signaling. And it's a member of the Syk tyrosine kinase family. Syk is in B cells, though. So anyhow, it's typically expressed in CLL cases with unmutated heavy chain genes. And it's thought to sort of enhance antigen receptor signaling. At various points, it's been proposed as a surrogate marker, if you will, of immunoglobulin gene mutational status. And there was some excitement that potentially you could, since you can usually detect proteins much more easily than sequencing, that you could develop a ZAP70 test and sort of not have to deal with mutation analysis of immunoglobulin genes. But the problem is this has been a lot more difficult than people realized, and a lot of the assays don't work well. And there's also some degree of discordance in the assays that do work between mutational status and ZAP70. Most clinical tests for ZAP70 are flow cytometry based, and they're nice because you can separately analyze T cells and B cells. T cells are typically ZAP70 positive, as I mentioned. So it's basically you've got a built-in positive control. Problem is these tests aren't standardized, they're difficult, you only get weak staining with the antibodies, and so the choice of negative control is very critical. And actually the flow cytometry community has been sort of like working with this for 6 or 7 years and really hasn't come up with much of anything, to tell you the truth. So, and the other problem is people who develop these assays don't validate them by looking at mutational status of their cases or clinical data. Clinical outcome data is very difficult. There are only a few labs, like one that's done that. But anyhow, and they also produce continuous distributions of ZAP. So that's really difficult to separate, CLL into good and bad prognostic groups if you've got kind of a continuous distribution of ZAP values. So we've got a much better assay here, so that's why I'm kind of plugging this. So we stain lymphocytes for CD519 and ZAP70, and then we use what we call an optimized isotypic control to set our negative threshold, and that's sort of shown here, where we're looking on the bottom panel, you're looking at B cells that have been stained with an isotypic control equal volume to the ZAP70 antibody and an isotypic control equal concentration. And both of these are if you use those as true controls, would indicate that normal B cells are ZAP70 positive, which they're not. So what we've done is we basically crank up the concentration of our isotypic control. And so we can ensure that at that concentration, normal B cells are negative. And then we go ahead and use the isotypic control at that concentration and then go ahead and look at CLL cases. And that's actually what we're doing here. So what we did is we compared our optimized isotypic control method to like the method where you take normal B cells and stain them with ZAP70 to set your threshold. And that's shown here. So this panel, the top left panel shows some normal B cells stained with ZAP70, and we've got this line over there. And then the top panel to the right shows a CLL case stained with our optimized isotypic control. And you can see then that if you use that isotypic control and stain the CLL cells then with ZAP, you get a much higher value for our isotypic control than you do with the control, than with the threshold generated by staining the normal B cells with ZAP. So the bottom line is there are some differences here, and I could go into why we think there are differences. So the interesting thing, though, is that using our method, so we did a study looking at 75 cases of CLL, and it turned out our isotypic control method generated a bimodal distribution where using the normal B cell control generated the quote-unquote expected sort of continuous variable distribution that most people report, and that's shown here. So not only do we see a bimodal distribution, but we have really good correlation with mutational status, and that's what the last slide was going to show, so we can kind of skip that. So for a lot of reasons, we really like this assay and expect it'll be adopted by other people, hopefully before too long. So in any case, just looking at comparing ZAP IgVH versus staining tests, you know, the nice thing about immunoglobulin gene analysis is it's less subjective. I mean, you just have to count mutations. So that's nice. And the problems, as I've said, with ZAP70 is that there's a lot of variability among different labs, and you can't really believe what's out there. It's really a mess. And the other problem is that surrogates for VHG mutational status are really not required now. I mean, sequencing, you know, 10 years ago was a lot more difficult than it is now. So it's fairly straightforward. It's not a problem. So there's no real reason not to do it. And plus, by doing the VH testing, you actually get the segment that's used that may have clinical significance, like with the V321 gene. However, ZAP70 testing, it may provide additional, you know, independent prognostic information above and beyond the mutational status, in that they're rare. There's a little bit of discordance, and so if you had a mutated case that was ZAP70 positive, that may do worse than one that's ZAP70 negative and that sort of thing. So I'm going to just try to say a few things about cytogenetics, because I know Martha's going to talk about this, but it's about 80% of cases show cytogenetic abnormalities that you can pick up by FISH that are listed here. Deletion 13q in about half the cases. That involves a microRNA, miR15A16-1. This is potentially a tumor suppressor that's sort of interesting. And then 11q22 deletions, the ATM, ataxia-telangiectasia mutated is located there. And then trisomy 12 pops up, and then deletions of p53 at 17p13. I mean, CLL is interesting that you don't see a lot of these translocations that you see in other lymphomas that involve chromosome 14, which is the immunoglobulin locus. This is kind of a busy slide, but just I put in to highlight the fact that with cytogenetics, I mean, people typically get cytogenetics and other kinds of testing, but cases that have got 17p or 11q deletions basically do poorly regardless of whether their immunoglobulin genes are mutated or not. And that's what's shown here. I wish the pointer would work. The top line basically shows the cases that have got neither 17p or 11q deletions and they're mutated. The one down below just shows the mutated cases. So the 11q deleted cases, whether they're mutated or not, do as poorly as the mutated. So the bottom line is you have to use cytogenetics in conjunction with, you know, mutational status to interpret what's going on. Now, I apologize for this slide, and especially without a pointer. Maybe I should just manually point. But the point here is that unmutated cases of CLL are more likely to have these bad cytogenetic abnormalities, 17p and 11q. This is a study that was done in 2002, highlighting the fact that maybe 2% of their mutated cases had 17p and 11q deletions, whereas, you know, half potentially had 11q and about 20% had deletion of 17p. And this was using 188 patients. So the other thing that's interesting, if you look at clonal evolution of CLL over time, the unmutated type of CLL is more aggressive and is more likely to acquire these bad cytogenetic abnormalities. In this particular study of 64 patients, 11 progressed over the observation period, which was 42 months, and all of them were unmutated cases, the cases that had unmutated VH genes. So in a way, it's like unmutated CLL is intrinsically more aggressive than mutated. Monoclonal B-cell lymphocytosis, I'm going to kind of wrap up here quickly. As I mentioned, I was going to come back to this. So this represents a diagnosis you can make if you've got less than 5,000 monotypic B cells per microliter, which, as I mentioned, may get revised upward, because this 5,000 cutoff is arbitrary and doesn't really identify patients who are going to necessarily go on and need treatment. To make it, you can't have symptoms of a B-cell neoplasm, no organomegaly or something like that, or marrow infiltration. And it's very common. The initial studies that came out maybe 10 years ago or 8 years ago basically identified it in 3.5% of normal individuals donating blood at a blood bank over the age of 40. And since this study came out, more sensitive flow cytometry tests have identified it in maybe 10% of quote-unquote normal individuals over the age of 50. So this is sort of a flow cytometry identified phenomenon, if you will, but it's real. And a paper that came out in the New England Journal in 2009 indicated that basically all cases of CLL are preceded by these small monoclonal CLL phenotype populations. And the interesting thing too is that it only occasionally evolves into CLL. There was a paper in the New England Journal in 2008 that looked at a lot of patients, and the only ones that progressed to CLL in this monoclonal B-cell lymphocytosis group were those that had lymphocytosis. And then only 1% of those per year progressed. So it's very rare. And this is just these are some flow histograms highlighting that. Basically, this is complicated for the non-flow people out there, but so the CLL phenotype is this thing in blue. Okay, so these are B cells because they express 19, but they express 5. And you can, and this is not uncommon. In these small population monoclonal B-cell lymphocytosis cases, you also have normal B cells mixed in with the CLL cells. And then, so you can see that here they are. In this particular case, I think the CLL phenotype cells represent maybe 50 cells per microliter. And they express weak CD20. This is kappa and this is lambda, and we're showing it based on 20, so these are all B cells. So you can see that there's weak expression, monotypic expression of kappa relative to lambda. And these cells also express CD23. So that's the CLL phenotype in a small population of cells in some normal individual. Now this is a bit busy, but it's a great table. This appeared in this New England Journal paper where they were looking at progression of monoclonal B-cell lymphocytosis cases. And the reason I'm putting it in here is they sort of divided up their cases into those without lymphocytosis and those with lymphocytosis. Lymphocytosis was defined as a lymphocyte count greater than 4,000 per microliter. And the interesting thing is that all these cytogenetic abnormalities that I mentioned, well, not all, but the standard ones that appear in a lot of cases, 13q deletion, trisomy 12, they're already present in these monoclonal B-cell lymphocytosis populations. So presumably these are early lesions that happen very early on. And they're also present in the same frequencies you see in full-blown cases of CLL. So that's very interesting right there. And the other thing that's very interesting is that most of these cases have mutated immunoglobulin genes, 85%, 90%, okay, of these small monoclonal B-cell lymphocytosis cases have mutated immunoglobulin genes. So since when we look at full-blown CLL, it's like 50-50. This suggests that the non-mutated type of CLL doesn't hang out as long in this monoclonal B-cell lymphocytosis stage as the mutated ones go. Again, just sort of confirming that it's more aggressive disease. And also, this is I think I'm getting close to the end here. I don't want to cut Martha short, but this came out of a paper that appeared in Blood showing that the repertoire and immunoglobulin gene repertoire of monoclonal B-cell lymphocytosis differs from CLL. So in this particular example, I think you looked at 65 cases, and you can see that the genes that are frequently present in CLL, like V434, are not seen in this monoclonal B-cell lymphocytosis, whereas genes that aren't really seen much in CLL are seen in this. So it looks like then there's some antigen selection process going on, going from the monoclonal B-cell lymphocytosis stage up to the full-blown CLL stage. And then this is just sort of a model slide that I pulled out of a paper a year or two ago that Della Favera put out, but basically highlighting that this is the current thinking now, is that CLL, the mutated CLL and the unmutated CLL may derive from different B-cell populations. The mutated may go through the germinal center. The non-mutated may represent some sort of like marginal zone B-cell or something that's actually expanding outside of a germinal center. The monoclonal B-cell lymphocytosis is here, and they've got chronic antigen stimulation, but they should also have chronic antigen stimulation here, because it looks like from the slide I just showed you that to go from this stage to this stage involves antigen stimulation. And then again, the unmutated type of CLL just intrinsically is more aggressive than the mutated type of CLL. All right, well, I'm going to turn the time over to Martha because I'm already cutting way into what she's got.
David asked me to provide some clinical perspective in CLL, so there's the pointer. And I thought I'd try and illustrate this with a couple of cases as well. Talk a little bit about factors affecting prognosis and then treatment and new approaches. So Let's see, the clinical presentation of CLL is usually patients have an incidentally noted elevated white cell count or asymptomatic adenopathy, and this prompts workup. The median age is about 72 when we look at population-based studies rather than sort of clinical trial-based studies. Most patients are older than 60, males greater than females, and as Dave said, there's a European, most of the patients are of European descent. And he went through the diagnosis of CLL pretty well, the common immunophenotype and the question about SLL and MBL. So once we have a diagnosis of CLL, then we stage the patient, and this is a clinical staging procedure, which is very easy. It's based on the physical exam and the white blood cell count only. So Conti Rai published this in 1975, and stage 0 is lymphocytosis only. Stage 1, patients had lymphadenopathy. Stage 2, some hepatosplenomegaly was noted. Stage 3 is low platelets, and stage 4 is low hemoglobin. And there's some modifications of this. Benet is very similar, and it's used more commonly in Europe. But this Rai staging is actually continues to stratify patients really well as far as how they'll do. So patients with stage 0 disease have a greater than 150-month median survival, whereas those with thrombocytopenia or anemia have about a 19-month, 50% overall survival. So it spreads people out very well as far as their risk. So just to illustrate some of the points, so case 1 is a patient that I saw. I think it was one of the first patients I saw when I got here. She was trying to save money. She went to a health fair, and they did a CBC, and they noticed that her white cell count was elevated. And so her white cell count was 27,000 per microliter. Most were lymphocytes. She had a little bit of adenopathy, no hepatosplenomegaly. And she had a bone marrow done at that time, and it was diffusely infiltrated with these small lymphocytes with characteristic CLL phenotype. So she had Rai stage 1 disease. So I expected her to do very well and followed her along. And I tried to depict her clinical course here in this graph of her CBC. So blue is white cells, red is hemoglobin, and platelets are green. And here's where she was diagnosed there at the end in 1997. And then we started feeling a spleen tip. And this slowly progressed so that by about 5 years, she had really symptomatic splenomegaly. And her platelet count began to drop. You can't, well, it's that green line there. And her hemoglobin, you can barely see that it had dropped down towards 11 or so. So she didn't have any other disease to treat, so we decided to take out her spleen. And it worked. So she had a reactive thrombocytosis, and it has come down. Her platelets have been in the normal range. Her white cell count has remained about 30 to 40,000, and her hemoglobin is about 14.5. And we're now at this 14-year point. So she's doing great. She's required no further treatment, and her disease has been very stable. So the next case is sort of similar, except that he presented a decade later, and he's a 41-year-old male. He went to his doctor because he had a rash, which was not, and didn't matter ultimately. But he had a white cell count of 27,000, and it was all lymphocytes. He had no adenopathy and no hepatosplenomegaly. And flow cytometry of his blood now. We don't have to do bone marrows all the time in patients to make a diagnosis now. So showed a typical immunophenotype for CLL. He had Rai stage 0 CLL, so he should have had a great prognosis, greater than 150 months. Unfortunately, this depicts his clinical course. So the range of dates is only 42 months, and here's where he was diagnosed. We watched his white cell count climb sort of inexorably. Lymphadenopathy developed and grew really pretty rapidly. He started to become anemic. His platelets started dropping. So at this point, he had really pretty bulky adenopathy, and we decided to treat with a typical 3-drug regimen. He did well with that treatment, but really just had a partial response. And at that point, given that he had a partial response, we suggested that, and he was young and could undergo allogeneic bone marrow transplant, we suggested, well, I think we need to do that. So he was undergoing workup for that, but then his adenopathy in his abdomen started growing and became symptomatic, so he was treated with radiotherapy with some benefit. And then as we know that going into allogeneic bone marrow transplant, if patients have uncontrolled disease or bulky disease, they don't do as well, and his disease actually started to grow through here. So we treated him with ofatumumab, which is a new monoclonal antibody that we can use for refractory CLL, and then also high-dose corticosteroids, and he actually had a nice response to those. And he proceeded to allogeneic bone marrow transplant. Unfortunately, he had a very difficult course and died actually just last month at 42 months. So wouldn't have predicted that from his initial presentation. So how can we divide these patients up now and sort of and use that information for their treatment? Well, the overall prognosis for CLL is depicted in the darker line with the triangles. That's the most recent population-based study. And it actually shows poorer prognosis than what we usually think, with a median overall survival of about 5 years. I think most of us think for all comers it's about 8 to 12 years. So this was a little bit of a surprise. And most patients are dying of their CLL. 70% are, which is different from what we hear about in medical school. So prognostic factors, 20th century, so the first lady, that was still 20th century. Stage, age, pattern of bone marrow involvement, and lymphocyte doubling time is what we went by. Now we have these additional sort of biologic prognostic markers that Dave reviewed, chromosomal abnormalities and the mutation status. So patients who are older do worse with CLL. The bottom line there with the X's, those are patients who are 80 or over. And this is their relative survival, so relative to 80-year-olds who do not have CLL. So you can tell that those patients are dying from their CLL, and they do worse than younger patients, which are depicted in the upper lines. So we can use cytogenetic abnormalities, as Dave said, to try and predict risk, and this was from that original paper. And here we developed with Dr. Chen a CLL fish panel that's a little bit less involved, looking for those 4 abnormalities. And this just shows the rates of those abnormalities in Utah versus other publications. And fortunately for us, I think, patients with ATM deletions and P53 deletions seem to be less prevalent here in Utah than in other publications, which is interesting. I don't have a reason for that. And this is a similar slide to what Dave showed, just showing how the cytogenetic abnormalities really do help parse out patients' risk. So this line, the first line there, the dark line, is P53 mutations with a median overall survival of only 32 months, versus the dotted line on the edge, the hash line on the edge on the far right, is those with 13q deletions, and their median overall survival is about 130 months, so much, much better. And then sort of intermediate in between. ATM deletion is the dotted line towards the left, and their median overall survival is about 80 months. And then somatic mutation of immunoglobulin variable region is also important, as Dave said. And this, as well as CD38 and ZAP70, I sort of think of them as similar prediction. Those who do not have the negative prognostic factor have a median overall survival of 24, 25 years or greater. And that's depicted here, CD38 and ZAP70 with the negative and positive prediction. So I just sort of think of it, if they have the negative prognostic factor, then their median overall survival is, say, 9 to 14 years. And if they don't, then 25 years or greater. So they should do very well. So going back to the cases, in case 1, well, do we have any more information? Not really, because we didn't have any of these other predictions, but so our prediction was that she would live for over 100 months, and she has. She's done very well, even on the far side of that spectrum. Now, the younger man in 2008, we did have a lot of these prognostic factors, except for the IGVH mutation status wasn't available at that point. So he had CD38 negative disease, cytogenetics were normal, but he did have this P53 deletion in 50% of his cells. Interestingly, in a subset of the cells, he had trisomy 12 deletion in 15 of 500. And he was ZAP70 positive. So by that, a lot of these predicted good overall survival, but it's trumped, as Dave said, by this poor cytogenetics. And that was certainly illustrated, unfortunately, very well in his clinical course. So treatment of CLL is guided by certain tenets. So we know that it's incurable with standard approaches, but it's highly treatable, and we have lots of different modalities for treatment. There's no randomized trial showing that overall survival is benefited by early treatment. And patients can be asymptomatic for years, so that guides our watch and wait sort of approach for patients who do not require treatment. And the goal of treatment is palliation of symptoms and avoidance of complications of progressive CLL or of the treatment. I think the quality of response is important because it is correlated to response duration. So quality of response to first treatment is correlated with the length of the response from treatment. And so those patients who have better quality of response don't need to be retreated quite as soon. So I tend to try and get the best quality of response I can. So triggers for treatment are symptoms clearly referable to CLL, like drenching night sweats or debilitating fatigue, progressive disease causing worsening cytopenias, bulky adenopathy or symptomatic splenomegaly. An elevated white cell count alone doesn't trigger treatment, and poor biologic predictors don't trigger treatment alone. So we really have to get an idea of how the disease is going to progress in these patients before treatment. So the available treatments include chemotherapy. Alkylator therapy is very important. Chlorambucil is a classic medication used in CLL. Purine analogs such as fludarabine, especially fludarabine. Bendamustine is a newer drug that has alkylator and purine analog activity. Immunotherapy is very important, and you've probably heard about rituximab. It's a chimeric anti-CD20 monoclonal antibody that's very important in the treatment of B-cell malignancies. Ofatumumab is a newer second-generation anti-CD20 antibody. It can be used in patients who have Rituxan refractory disease, and the idea is that it actually it was designed to recognize a different epitope of CD20 antigen and perhaps overcome some patients with rituximab resistance. Alemtuzumab is another antibody that's commercially available. It's directed against CD52, which is not as targeted, so it's expressed on other lymphocytes, T lymphocytes, and monocytes as well. Its use is limited to some degree by side effects, mainly bone marrow suppression, and infections can be a real problem. We know that if we add rituximab to chemotherapy, patients do better with their responses and actually overall survival, so we try and use those together. Corticosteroids can be very efficacious. Immunomodulatory agents such as lenalidomide or thalidomide can be very helpful. The sort of ultimate, at least I think, immunotherapy would be allogeneic bone marrow transplant. It's limited by availability of a donor and patient comorbidities. Splenectomy and radiotherapy are sort of adjunctive treatments as illustrated by those two cases. So in this era of personalized medicine, can we use risk-adapted initial therapy? And I would argue we've been doing this forever in CLL, actually, because we take into account patient-related factors and disease-related factors all the time. So we never have used a one-size-fits-all approach. But can we use these biological risk factors to predict response or duration of response? And the answer is kind of. And I think it's an area of active investigation right now. So unfortunately, I don't have a long list of treatments on the far, whatever that is, left. And then, a bunch of risk factors and say whether or not the treatment will work. I do have that for high-dose rituximab. That's rituximab given at probably 5 times the dose that we usually use it. But they did try and stratify response, and they did show that we could do that. So high-dose rituximab is probably effective in patients with ATM deletions and 13q deletions, but not if they have a p53 deletion or trisomy 12 or normal cytogenetic. So it helps us say, well, we shouldn't use that, or maybe we should try that modality. Some other tidbits we know, well, patients with ATM deletions probably respond better if an alkylator is included in their regimen, so try and include an alkylator in their initial regimens. And then p53 deletions, they will respond fairly well to high-dose corticosteroids or to alemtuzumab because they seem to trigger apoptosis through a non-p53 mediated modality. So then, as far as predictions of poor duration of response, well, I think IGVH unmutated CLL and p53 deletion CLL, those are characterized by short duration of response to initial therapy. So that generally triggers well, maybe we should try and consolidate those patients' initial response with something like an allogeneic bone marrow transplant. And these are available for more patients now because they can be done with reduced intensity. So the point is not to kill every CLL cells with very high doses of chemotherapy. It's more to, that patients are given some chemotherapy to render them fairly immunosuppressed. And then a graft is given and they end up being a chimera. They sort of have a chimeric bone marrow for a while. But it really takes advantage of this graft versus leukemia effect rather than high doses of chemotherapy to eradicate the CLL. And it's been shown that this is actually true. This does occur. And event-free survival of patients at 4 years with one report is about 42%, which is pretty good for these high-risk patients. But the problem is that the non-relapse related mortality at 4 years in this paper was about 23%. So it's a very risky procedure. So it's not the cure-all, but it is an option for some patients. So in this cartoon here, it just shows sort of where the field is moving and additional targets for potential treatment for CLL. So this is a CLL cell. Up on the top are monoclonal antigens that can be targeted by monoclonal antibodies. I added that CD38 there because we have a phase 1 trial here looking at the activity or the safety and tolerability of anti-CD38 as a target in CLL cells. It also depicts some of the signal transduction pathways that can be targeted by small molecule inhibitors, including SYK, as was mentioned before, BTK as well. PI3 kinase over on the left there, we are also initiating a study looking at inhibiting PI3 kinase. And then other treatment approaches include disrupting the interaction between the microenvironment and the CLL cells, also trying to depress maybe the T regulatory effect, the immunosuppressive effect of Tregs by interrupting the CD40 ligand, CD40 interaction. There's actually a CD40 antibody that we're testing as well. Or using allogeneic T cells, like in the allogeneic bone marrow transplant. You may have read in the Times or the New England Journal in the fall about a really pretty spectacular study in which patients' own T cells were transduced with a lentiviral vector to express a T cell receptor that could recognize CD19. And these were reinfused into the patient. Nothing happened for 2 weeks, and suddenly he got very ill. And they discovered that illness was actually tumor lysis syndrome. So they subsequently discovered that those T cells that they had infused had proliferated in the patient, and then I guess got to a critical mass, and then which was associated with massive cell kill of those B cell CLL cells. And then after a couple of days, they did a bone marrow. They couldn't see CLL in the guy anymore, and all of his lymph nodes went away. And then he recovered, and as far as I know, he's still doing okay. So that's very interesting treatment modality that's using sort of these chimeric antigen receptor T cells, and various groups are looking into that for treatment of B cell malignancies and other malignancies as well. So to sum up, all CLL is not the same. There are probably two main biologic subsets reflected by the immunoglobulin mutation status. The clinical behavior is further determined by genetic abnormalities impacting proliferation, apoptosis, and drug resistance. And we're developing a better understanding of the biology, and it's giving us clues to the divergent clinical behavior and uncovering, we hope, novel targets for treatment. That's all I have.
We mentioned immune deficiency and hypogammaglobulinemia. How many of them actually require IVIG?
Yeah, so the indication for IVIG replacement is not just hypogammaglobulinemia, but that coupled with recurrent serious bacterial infections. And so that's a real minority. I would say maybe 10%.
It's interesting because I've seen a reasonable number of MGUSs and myeloma present in my clinic, but I've never seen a CLL. And I presume that's because they have elevated white.
Yeah. And really, people's immunity, at least clinically, seems to be preserved at the beginning of their disease, sort of like what Dave was saying. But as they progress, and I think their tumor burden goes up, and also with repeated treatments, which also affects immunity, that becomes more and more of a problem. Yes, you can see monoclonal, so Harry just asked if you can detect a monoclonal paraprotein, and you can in CLL patients. I think it can be either IgG or IgM, and the rate is somewhere around 10 to 15%. It's not very many. Okay, thanks very much.